Today, we're plunging into a world that's governed by these tiny chemical whispers, the universe of sex hormones.
It's incredible, really.
These powerful molecules, estrogens and progestins, they don't just, manage fertility and reproductive cycles.
Not at all.
They are absolutely foundational to our health. They govern everything from the strength of your bones and the health of your arteries, all the way to, well, your mood.
It's a field of medicinal chemistry that sits, like, right at the intersection of life sciences and engineering. And you'd think, wouldn't you, that nature's own chemical messengers would be the best medicine?
Right, just use what the body makes.
Exactly. But as our stack of sources here shows, the story is so much more complicated. We have an incredible amount of material covering the precise chemical structures, the massive health applications like hormone replacement therapy, and the surprising ways that scientists had to essentially invent whole new classes of drugs just to make them work when you swallow them.
And that's really our mission today. We want to give you a high-definition shortcut to understanding this entire landscape. We're going to unpack that delicate balance between estrogens and progestins.
A balance that, when it's disrupted or, improperly managed, it can lead to both incredible benefits.
Right, like protection against certain cancers.
And some very, very serious risks, like blood clots. We're going to distill the clinical consensus from some really controversial studies.
And we can start right at the very beginning with this historical footnote that sort of sets the stage for everything that follows.
Yeah, early last century, before we even knew what these compounds were chemically, scientists had to identify them by function.
How did they even do that?
They looked for substances that could induce estrus or, reproductive readiness, heat in spayed animals.
So they were just looking for a biological effect.
That's it. That search defined the entire class of estrogens, and, well, it ultimately led to the isolation of estradiol in its pure form by 1929.
And that initial discovery immediately introduced the central pharmacological problem we are still grappling with today. Natural hormones, for all their power inside the body, they're almost useless when you take them as a standard pill.
Yeah, they're too quickly metabolized. The liver just breaks them down.
Right.
Exactly. And this metabolic challenge is what forced chemists to create entirely synthetic versions. Drugs that looked just enough like the natural hormones to fit the cellular lock, but were structurally different enough to bypass the body's rapid breakdown systems.
That's where the story really begins.
That creation of orally potent synthetic hormones is where we truly begin to appreciate the cleverness and, well, the complexity of hormonal medicine.
So let's establish that foundation with estrogens. As you said, we knew hormonal control of the reproductive cycle existed around 1900, and estradiol was isolated in 29. But what exactly is an estrogen chemically in the context of the human body?
Fundamentally, estrogens are steroids. They're all derived from cholesterol, and they're defined by their ability to induce the changes needed for reproduction.
So that early definition of inducing heat in animals sort of stuck.
It did, but in humans, we really focus on the big three natural estrogens that circulate in the blood: estradiol, estrone, and estriol.
And estradiol is the reigning champion of potency, is that right?
It is the powerhouse, no question. Estradiol is the most potent, and it's the major estrogen secreted by the ovary during the reproductive years.
But the others are still active.
Oh, absolutely. Estrone and estriol are certainly active, and they're circulating, but estradiol is the primary driver of all those physiological changes we associate with estrogen.
Okay, let's look at where they come from. It's always fascinating to me that these quintessential female hormones are manufactured from, well, male hormone precursors.
That's the key piece of the chemistry. It's a beautiful bit of biology. Estrogens are synthesized primarily in the Graafian follicle of the ovary, the corpus luteum, and then during pregnancy, the placenta.
But they don't start from scratch?
They don't. They start from androgen precursors. We're talking testosterone or androstenedione. The final pivotal step is a chemical transformation called ring A aromatization, which converts these androgens into active estrogens.
Wait, can you simplify that process? It sounds like we're taking the blueprints for a male hormone and just tweaking one crucial section to turn it into a female hormone.
That's a perfect analogy. You're taking a precursor molecule, a testosterone backbone, and an enzyme called aromatase, makes this small, targeted chemical change to what we call the A ring.
And that little tweak.
It completely transforms its function, turns it right into estradiol.
And this leads to a really surprising insight that men are constantly performing this chemical conversion as well.
Absolutely. This is the detail that often catches people off guard. Human males produce small but continuous amount of estradiol,
How much are we talking about?
typically around 2 to 20 micrograms per day.
Yeah.
And it happens through the exact same aromatization process, primarily in the testes and in what we call extraglandular tissues like fat cells.
So it's the same process, but the function must be different.
Right. It plays more of a regulatory role rather than a cyclical one, but the chemical pathway is identical. It's shared.
So how is this whole system regulated during the menstrual cycle? What dictates when the tap turns on and off?
The flow is incredibly dynamic. Daily secretion in a cycling woman can vary dramatically, rising from about 10 micrograms per day all the way up to 100 micrograms a day or even more.
And that depends on where she is in her cycle.
Exactly. The process begins under the direction of a pituitary hormone, FSH, which stimulates the Graafian follicle to produce estrogen. Levels then peak right before ovulation.
And then after the egg is released.
After the egg is released, the corpus luteum takes over and continues the production, mainly of progesterone, but it also maintains estradiol levels.
And the mechanism that keeps this whole cycle running smoothly is a classic negative feedback loop, right?
Precisely. Estrogens act as their own brake. They inhibit the secretion of FSH, and when estrogen levels get really high, they also inhibit LH release.
So it's a self-regulating system.
A very tightly choreographed dance. This feedback acts directly on the pituitary gland and also through the central controller, the hypothalamus. It's all designed to maintain that rhythm and prevent overstimulation.
Let's shift to the key physiological roles. When we talk about what estrogens build, what is their primary function in the body?
They are the master builders of the female reproductive system and, the defining secondary characteristics. They drive all of that pubertal growth, the uterus, fallopian tubes, the vagina, all enlarge.
And the endometrium.
Yes, they cause the rapid proliferation, the thickening of the endometrium, which prepares the lining for a potential pregnancy. They also transform the vaginal epithelium and create that characteristic watery, alkaline cervical mucus,
Which is key for fertility.
essential for facilitating sperm transport.
And what about outside of the primary reproductive organs?
Well, they're responsible for the secondary sex characteristics, the development of breast ducts, stroma, fat depositions, all the things that define feminine contours. They also have an impact on behavior and mood.
But their most critical non-reproductive role, and this is something we focus heavily on in HRT, is their anabolic power, particularly on the skeletal system.
Oh, absolutely.
Can we elaborate on that anabolic role? Because bone density is a huge factor, especially postmenopause.
It's massive. Estrogens promote the fusion of the epiphyses. They essentially close the growth plates, which signals the end of the pubertal growth spurt.
But for adult health?
More importantly, for adult health, they are absolutely vital for maintaining bone mass. And they achieve this not by, say, making new bone rapidly, but by stopping the bone from being dismantled.
So they are protecting existing bone rather than building massive amounts of new bone.
Exactly. They retard bone resorption. They inhibit the activity of the osteoclasts. Those are the cells responsible for dissolving or chewing away old bone tissue.
They shut down the demolition crew?
That's a great way to put it. By shutting down the demolition crew, they allow the building crew, the osteoblasts, to keep the balance positive. They also help promote a positive calcium balance, partly by enhancing the activity of vitamin D. It's an essential maintenance function.
And that's why estrogen deficiency postmenopause leads directly to osteoporosis risk.
It's a direct line.
Okay, now for the metabolic and systemic effects, which is where we get this paradox. Estrogens are often credited with the lower incidence of cardiovascular disease in premenopausal women.
Right.
But they also have this dangerous flip side. Let's start with the good stuff, the beneficial effects on the cardiovascular system.
The beneficial side is largely related to the lipid profile. Estrogens shift the balance of cholesterol in a really positive direction. They decrease the bad LDL cholesterol while simultaneously raising the good HDL cholesterol and triglycerides.
Which creates a healthier ratio.
It creates a highly beneficial ratio that's associated with a much lower risk of atherosclerosis or, plaque buildup. They also promote vascular health by inducing vasodilation, helping blood vessels relax.
That all sounds fantastic, but the sources make it very clear that this benefit comes with a non-negotiable risk when it comes to blood clotting.
This is the double-edged sword that defines the use of oral estrogens. They significantly increase the blood's tendency to coagulate.
How do they do that?
They do this by instructing the liver to increase the synthesis of key clotting factors. We're talking factors 2, 7, 9X, and X. This heightened coagulability is the mechanism behind the increased risk of venous thromboembolism, or VTE, a major clot risk.
They also impact how other chemicals are transported in the blood, is that right?
Yes, they increase the plasma levels of various binding globulins, sex hormone binding globulin, thyroid binding globulin, corticosteroid binding globulin.
And one other thing, gallstones.
Right. Finally, they alter bile composition. They increase the lithogenicity of bile, which is just a fancy way of saying they increase cholesterol secretion into the bile.
Which raises the risk of developing gallstones.
Unfortunately, yes. So you have this compound that is simultaneously great for your blood vessels and, well, pretty terrible for your clotting risk.
And this complexity brings us right back to that fundamental problem we identified at the start, the necessity of synthetic hormones. Why exactly is natural estradiol so ineffective when you take it by mouth?
It all comes down to what we call first-pass metabolism. When you swallow a pill, the active ingredient is absorbed through your gut, and it passes directly to the liver via the hepatic portal circulation.
Before it gets to the rest of the body.
Exactly. And the liver is the body's primary detoxification center. It sees natural estradiol as this foreign substance that needs to be rapidly broken down and excreted.
So the liver basically processes and destroys the hormone before it can even reach its target tissues.
Precisely. It's like sending a package through the mail. But the sorting facility intercepts and shreds like 95% of it before it ever gets out the door. The hormone has a very, very short duration of action.
So chemists had to get clever.
To overcome this, chemists made these slight but pivotal modifications to the estradiol molecule.
And that solution gave us the workhorse of modern contraception, estradiol.
Estradiol is the perfect example of medicinal chemistry stepping in. By adding a small chemical group, an ethinyl group, at a very specific position on the steroid ring, they essentially created a shield.
And this
modification protects the hormone from that rapid hepatic breakdown.
What's the result pharmacologically? I mean, how much of a difference does it make?
A huge difference. The half-life, the time it takes for half the drug to be eliminated, jumps from just a few hours to 12 or even 24 hours.
Wow.
Yeah. This slow breakdown makes estradiol highly potent and reliably active when taken orally, which enables that daily dosing for contraception or HRT. It's a purely engineered solution to a biological problem.
Before we discuss the delivery systems, let's briefly touch on how these hormones actually, command the cells. It all comes down to the receptors.
It does. Estrogens are not like water-soluble drugs that act on the cell surface. They're fat-soluble steroids.
Which means they can pass right through the cell membrane?
Easily. And they act primarily by binding to specific nuclear receptors, or ERs, located inside the cell nucleus.
And once they're bound, they don't just sit there, right? They become part of the machinery that dictates which genes are switched on or off.
They turn into what we call transcription factors, the activated estrogen receptor complex. It dimerizes, which means two of them join together, and they then bind to these DNA sequences called estrogen response elements, or EREs.
And that binding is the signal.
That binding attracts coactivator proteins, which then initiate the transcription of specific genes. It essentially starts the manufacturing process for new proteins.
And this is where the complexity truly starts to layer on, because we don't just have one type of receptor, we have two key subtypes.
That's critical, ERI and ERI. Now, the natural hormone, estradiol, it binds equally well to both. However, these subtypes are distributed differently throughout the body.
Okay, so where do you find them?
ERI dominates in tissues like the uterus, the breast, and bone. It drives those proliferative effects. ERI tends to be more prevalent in the prostate, ovaries, and certain areas of the brain.
And if a drug can selectively target one receptor over the other or alter how that receptor behaves,
then you can start getting very, very clever with drug action.
that's the whole game.
That is the entire premise of the selective estrogen receptor modulators, or SERMs, which we'll definitely get into later. But this mechanism of action is why different ligands, different drugs, can have dramatically different effects, even though they're all technically binding to an estrogen receptor.
So if a drug is an antagonist, a blocker, what is happening at that receptor level? Is it just sitting there blocking the spot?
It's more than that. An antagonist forces the receptor into a slightly different shape or conformation. When it tries to bind to the DNA, it can't recruit the coactivator proteins that switch genes on.
It recruits something else instead.
Instead, it recruits copressor proteins, which effectively switch the gene off or block transcription. So it's not just blocking the binding site, it's changing the entire functional structure of the receptor complex.
Now let's circle back to delivery. This is maybe the most crucial takeaway for anyone considering HRT. The difference between swallowing a pill and using a transdermal patch is the difference between increasing your clot risk and potentially avoiding it altogether.
This is absolutely essential to understand. Traditional oral therapy, as we discussed, subjects the hormone to a massive first pass through the liver. Even if the systemic dose is low, that initial high concentration passing through the liver dramatically stimulates the production of liver-synthesized proteins.
And which of those proteins are the problem?
The undesirable ones, the clotting factors. By driving that high initial concentration through the liver, oral delivery maximizes the synthesis of those factors, the same ones that increase the blood's tendency to coagulate and lead to VTE.
Okay, so in contrast, how does the transdermal patch, like estradiol TTS, bypass this issue?
The patch delivers the hormone directly into the systemic circulation through the skin. It avoids the hepatic portal circulation entirely.
So the liver never gets that huge initial dose.
Right. The liver only receives a much lower constant dose via general circulation, just as it would in a premenopausal woman.
So the consequence is profound. By avoiding the first pass, you avoid telling the liver to ramp up production of dangerous clotting proteins.
Correct. The key takeaway for the listener is this. With transdermal HRT, plasma levels of those key liver proteins, TBG, CBG, angiotensinogen, and those critical clotting factors are not elevated. Therefore, the risk of venous thromboembolic phenomena may be low or even non-existent compared to conventional oral doses. This metabolic difference is why transdermal or vaginal delivery systems are so often medically preferred today, especially for those at risk.
Okay, moving into clinical practice, let's address HRT. Historically, this was marketed as, the magic pill to keep women feeling young and protected for decades. But the research has been a real roller coaster.
To say the least.
What are the core indications for using HRT today?
The indications have been narrowed down significantly. HRT is primarily used to address the severe, acute symptoms of menopause caused by the cessation of ovarian function.
So we're talking about quality of life issues.
Exactly. The debilitating vasomotor disturbances, the hot flashes, the drenching sweats, as well as managing urogenital atrophy, and, critically, bone loss.
But the primary reason a woman is prescribed HRT is often just to manage those immediate disruptive hot flashes, isn't it?
Yes. Controlling those acute vasomotor symptoms is the main clinical driver. They significantly impact sleep, mood, and just daily function. And HRT is incredibly effective for this.
Now let's revisit the initial belief. For decades, the medical community was convinced HRT was cardioprotective. What was the rationale behind that assumption?
It was a very strong, very logical assumption. Premenopausal women have a significantly lower rate of heart disease than men, and this protection just vanishes after menopause.
So the thinking was, it must be the estrogen.
Right. And since we knew estrogens improved the favorable HDL to LDL cholesterol ratio, it seemed obvious that maintaining estrogen levels post-menopause would continue to provide that cardiovascular shield. They were extrapolating observational data into prescriptive action.
But the clinical trials that actually tested this assumption, HERS and WHI, delivered results that completely shattered that model. Let's start with the HERS study.
The Heart and Estrogen Progestin Replacement Study, HERS, was the first major alarm bell. It was conducted in older women who already had established cardiovascular disease.
And the result?
They were immediate and troubling. HRT tripled the risk of venous thromboembolism. And worse, it provided no secondary protection against coronary artery disease. This was the first sign that the presumed benefit simply didn't materialize in women who were already ill.
And then came the Women's Health Initiative, the WHI, in 2002. This was the definitive turning point that caused a seismic shift in medical practice.
The WHI was a massive landmark trial. Tens of thousands of younger, generally healthier women, and the results were so compellingly negative that the study was terminated prematurely, which shocked the medical world.
What were the numbers?
The combined HRT arm showed a 24% increase in coronary heart disease events, a 40% increase in stroke, and a doubling of VTE events.
That's devastating. I mean, if you just read the headlines, the takeaway was simply HRT is dangerous and it increases heart attacks and stroke.
That was the headline, yeah.
But you mentioned a critical nuance, the timing hypothesis that emerged later when researchers revisited the data. What did that reexamination reveal?
This is perhaps the most important refinement in the whole HRT story. Researchers realized that the average age of women entering the WHI trial was 63. Often a decade or more after they had stopped producing estrogen.
Which is a long time.
A very long time. And when they stratified the data by age, they found something fascinating. Women who started HRT within 10 years of menopause or before age 60 actually showed a reduction in the incidence of myocardial infarction or heart attack.
Wait, so the exact same drug that hurt older women might actually protect younger postmenopausal women. That's a massive difference.
It's the timing hypothesis in action. The theory is that if the arteries are still healthy and relatively free of subclinical plaque, starting estrogen early is protective.
Why? What's the mechanism?
Perhaps due to its anti-inflammatory effects and that beneficial lipid profile. However, if a woman starts HRT years later, after plaque has already formed, the estrogen might destabilize that plaque, potentially leading to a clot or rupture.
So the timing of when you start therapy seems to dictate whether the drug acts as a protector or a risk factor.
It seems to be the most critical variable.
Okay, let's address the cancer risks, which are separate from the cardiovascular risks, but equally complex. If a woman with a uterus takes estrogen alone, what is the risk?
The risk of estrogen alone is focused entirely on the uterus. Unopposed estrogen, meaning estrogen, without a counterbalancing progestin, causes continuous stimulation and proliferation of the endometrium, the uterine lining.
And that leads to?
It significantly increases the risk of irregular bleeding and endometrial carcinoma by 5 to 15 times. It's a huge risk.
And that's why progestin is mandatory for any woman who still has her uterus. But here's the ultimate trade-off. When they combined estrogen with progestin to protect the endometrium, they stumble into another cancer risk.
That's the tragic complexity of hormonal medicine. The combined HRT arm of the WHI study, which used estrogen plus medroxyprogesterone, showed a significantly higher incidence of invasive breast cancer.
And the culprit was the progestin.
The data strongly suggests that the progestin component, specifically medroxyprogesterone acetate, was the culprit driving that increased risk. You add the progestin to save the uterus, but you increase the risk to the breast.
You're essentially trading one cancer risk for another.
Exactly. The benefit of endometrial protection appears to be counterbalanced by a procarcinogenic effect on the breast tissue, especially after 4 to 5 years of combined use.
Before we finalize the guidelines, what about cognitive health? Many hoped estrogen would protect against age-related cognitive decline. Did the WIMS study confirm that?
Unfortunately, no. The Women's Health Initiative Memory Study, WIMS, specifically looked at older women aged 65 to 79. It not only failed to show protection against cognitive decline.
What did it show?
The incidence of dementia actually doubled in the HRT group.
Doubled.
Doubled. And again, this may link back to that timing hypothesis. Starting HRT late in life may be detrimental to the brain, not protective.
So synthesizing all this complex, often conflicting data, what is the current strict clinical guidance on HRT prescription?
The current consensus is highly conservative. HRT should be used primarily for acute symptom management, those vasomotor disturbances and urogenital atrophy, and only in women before age 60 or within 10 years of menopause.
And the mantra is?
Use the smallest effective dose for the shortest possible duration.
And the final piece of the puzzle, when do you add the progestin?
If the woman has had a hysterectomy, meaning she has no uterus, she receives estrogen alone. If she has an intact uterus, she must receive estrogen plus progestin, prescribed either sequentially or continuously, to eliminate that high risk of endometrial carcinoma.
And just to close out the indications, HRT is no longer recommended as a first-line treatment for preventing osteoporosis, is it?
Correct. While it certainly helps maintain bone density, bisphosphonates are now considered superior and safer for the sole purpose of fracture prevention and osteoporosis treatment.
So HRT for bone health is really an off-label or secondary benefit at this point.
Right. It's usually limited to 5 years or less and not recommended past age 60 specifically for bone protection.
The incredible complexity of HRT really forced scientists to get smarter about hormone action. They needed drugs that could be protective in one tissue, say bone, while being antagonistic or blocking in another, like the breast.
Right.
And this led to the development of these smart drugs, the selective estrogen receptor modulators, or SERMs.
The SERMs represent a huge advance. They're defined by their ability to exert both estrogenic agonist and an estrogenic antagonist actions, but in a highly tissue-selective manner.
So the drug itself doesn't change.
The drug doesn't change, but when it binds to the estrogen receptor, it changes the receptor shape just enough to dictate which coactivator proteins it links up with in that specific cell type.
So it's the cellular context, the proteins available inside that specific cell, that determines whether the drug acts as an on switch or an off switch.
That's the key insight.
Ah.
The binding ligand, The drug changes the receptor's conformation, and depending on whether it's a breast cell or a bone cell, it interacts with different co-repressors or co-activators, and that results in that tissue-selective activity.
Let's look at the classic example, tamoxifen. It's a critical weapon against breast cancer, but it's a perfect example of the trade-off inherent in SERMs.
Tamoxifen is a potent antagonist in ER-positive breast cancer cells, which is why it's used for treatment and prophylaxis. However, it's a partial agonist, meaning it acts like estrogen in the uterus, bone, liver, and pituitary.
So it has this split personality. What are the resulting benefits and risks from that?
The benefits are substantial. It treats or helps prevent ER-positive breast cancer. Its agonistic action in bone helps maintain bone density, and in the liver, it helps lower cholesterol.
But the risks?
But the risks stem from that same agonistic action. Because it acts like estrogen in the uterus, it stimulates endometrial proliferation, raising the risk of endometrial carcinoma. And because it acts like estrogen in the liver, it drives up clotting factor production.
Which increases the VTE risk.
Right, it increases VTE risk 2 to 3 times.
So tamoxifen is effective, but it comes with two major, well-defined risks that require careful monitoring: uterine cancer and blood clots.
Absolutely. The clinical benefit has to be weighed very heavily against those two specific risks.
This created the need for a second-generation SERM with a cleaner profile, and that brought us raloxifene. How did raloxifene improve upon tamoxifen's structure?
Raloxifene achieved a much more favorable pattern of selectivity. It remains a powerful partial agonist in bone and on lipid metabolism, so it keeps the bone-protecting and cholesterol-improving effects.
But the key difference?
Crucially, it acts as a strong antagonist in the endometrium and the breast.
That is a massive difference. So what are the clinical benefits that follow from that?
Raloxifene is excellent for preventing postmenopausal bone loss. It reduces the risk of vertebral fractures by about 50%. It also significantly reduces the risk of ER-positive breast cancer, often by about 65%.
And the big advantage over tamoxifen?
Most importantly, because it is an antagonist in the uterus, it does not stimulate endometrial proliferation. It completely eliminates the endometrial cancer risk associated with tamoxifen.
That sounds like a clear winner, but there's always a catch. Does raloxifene still carry the VTE risk?
Unfortunately, yes. Because it maintains its agonistic action in the liver, it still increases the risk of deep vein thrombosis by about 3 times.
And it has another drawback, right?
It does. Unlike tamoxifen, which can sometimes help with hot flashes, raloxifene often induces or worsens them, which can be a real compliance issue for patients.
Okay. Moving beyond SERMs, let's discuss aromatase inhibitors, or AIs. This is an entirely different approach to hormonal cancer treatment. Instead of blocking the receptor, you eliminate the hormone source.
This is the scorched earth strategy, as some call it. It's primarily used in postmenopausal women with ER-positive breast cancer.
How does it work?
Remember we discussed aromatase, the enzyme that performs that final step of converting androgens into estrogens.
Right.
Aromatase inhibitors like letrozole and anastrozole and exemestane, they block that enzyme completely.
And the result being?
In postmenopausal women who rely heavily on extraglandular tissue like fat to aromatize androgens into estrogen, blocking this step leads to nearly total estrogen deprivation. This starves the estrogen-dependent cancer cells.
So how does their efficacy and side effect profile compare to tamoxifen?
Clinically, AIs are generally more effective in delaying recurrence and disease progression in the adjuvant setting than tamoxifen, and they have 2 massive safety advantages.
Okay, what?
First, they pose no increased risk of thromboembolic events, as they don't affect the liver's clotting factor synthesis. And second, they cause no endometrial hyperplasia or cancer predisposition. They cleanly bypass both of tamoxifen's major adverse effects.
That sounds almost perfect. What is the inevitable trade-off of total estrogen deprivation?
The trade-off is bone health. Since they eliminate estrogen across the entire body, they remove estrogen's bone protective effects. Unlike tamoxifen, which helps the bone, AIs accelerate bone loss.
So they predispose patients to fractures.
Exactly, and they are also associated with increased joint and muscle pain or arthritic symptoms. So the choice between a SERM and an AI often comes down to which risk you're more concerned about managing: blood clots and uterine risk with tamoxifen, or bone health with AIs.
Now we turn our attention to the second half of the hormonal equation, progestins. Their very name means for gestation.
Progestins are the preparation and maintenance crew. They are substances that convert the estrogen-primed proliferative endometrium into a highly vascular, glandular, and secretory lining ready for implantation.
And then they maintain that state.
And then maintain that state to support pregnancy.
The natural form is progesterone. When is it most active?
Progesterone is a 21-carbon steroid whose secretion just skyrockets during the luteal phase, the latter half of the menstrual cycle. The corpus luteum produces 10 to 20 milligrams a day under the influence of LH.
And if conception occurs?
If conception occurs, the pregnancy itself ensures that progesterone secretion continues, preventing the uterus from shedding its lining.
And just like with estrogens, scientists had to create synthetic versions to make them orally effective, which led to the 19-nortestosterone derivatives.
Correct. The most potent synthetic progestins are derivatives of testosterone, chemically modified to increase their oral potency. These include estrogens, like norethindrone, and gonanes, like levonorgestrel and desogestrel.
And the gonanes are the standard in contraceptives.
Yes, the gonanes are particularly potent at suppressing ovulation, making them the standard in most modern contraceptives today.
Beyond protecting the endometrium, what are the key physiological actions of progesterone?
Beyond that secretory change, progesterone makes a hostile environment for sperm. It converts the estrogen-induced watery cervical mucus into this thick, sticky, and scanty secretion that is basically impenetrable to sperm.
I see. And it affects body temperature, too.
Physiologically, yes. It also raises the basal body temperature slightly, about half a degree Celsius, which is why charting temperature is a classic way to confirm ovulation and the start of the luteal phase.
What are the potential drawbacks or adverse profiles of these synthetic 19-nortestosterone derivatives, especially since they are related to testosterone?
Well, they often retain some degree of androgenic activity. This means they tend to counteract the beneficial lipid effects of estrogen. They can lower the good HDL cholesterol and raise the bad LDL cholesterol.
So in combined HRT, they can neutralize some of the cardiovascular benefits the estrogen provides.
Exactly. And another critical concern is the potential for masculinization of a female fetus if these specific high-androgen compounds are used inadvertently in early pregnancy.
Okay, let's flip the switch and talk about antiprogestins, the drugs that actively block progesterone, often used for medical abortion. Mifepristone is the classic example.
Mifepristone is a powerful antiprogestational agent, but it also has significant anti-glucocorticoid activity, which means it blocks the cortisol receptor to some extent.
And its mechanism.
It's simple but effective. It blocks progesterone action on the endometrium, which destabilizes the uterine lining. This then unrestrains the release of local prostaglandins, which in turn stimulate powerful uterine contractions and lead to endometrial shedding and abortion.
What are its primary applications?
Its primary use is in the termination of pregnancy up to 7 weeks, usually administered in combination with a prostaglandin analog like misoprostol to maximize contractions.
But it has another use.
It does. It's also notable for its use as a highly effective postcoital contraceptive when taken within 72 hours.
And a newer drug, ulipristal, has extended the emergency window for contraception.
Ulipristal is a selective progesterone receptor modulator, or SPRM. It's similar to how SERMs act on the estrogen receptor. It was recently approved for emergency contraception.
And its major advantage?
Its major advantage over levonorgestrel is its extended efficacy window. It remains effective up to 120 hours. That's 5 days after unprotected intercourse.
How does it manage that?
It works primarily by inhibiting the LH surge, thereby suppressing or delaying ovulation. This gives women a significantly longer period for effective intervention.
Hormonal contraceptives they've revolutionized societal structures and family planning. They offer this incredible efficacy, 98 to 99.9% effectiveness for the combined pill. The sheer reliability is what sets it apart.
It's a near-perfect method when used correctly. But the underlying mechanisms differ significantly based on whether you are using a combined pill with estrogen and progestin or a progestin-only method.
And understanding those distinctions is key to understanding the side effects.
Absolutely.
Let's start with the combined pill, the most popular form. What is the single primary mode of action that guarantees success?
The primary action is ovulation suppression, and that's achieved through a synergistic effect of both hormones. The estrogen and progestin reinforce the body's normal negative feedback loop, but at a high enough level to completely shut down the pituitary signal to the ovaries.
And that stops the LH surge.
It abolishes the crucial mid-cycle surge of luteinizing hormone, or LH, which is necessary for ovulation to occur. No LH surge, no egg released. It's that simple.
So the estrogen provides the stable feedback signal, and the progestin ensures the suppression is complete and also provides local effects, right?
Yes. The estrogen is key for pituitary suppression and for cycle control, preventing breakthrough bleeding. The progestin component, however, provides that thickening of the cervical mucus and interference with the endometrium, acting as a powerful backup mechanism.
And how does the progestin-only pill or mini pill work, given that it's a much lower dose and doesn't always suppress ovulation?
The midi pill is entirely different. Because the dose is so low, ovulation still occurs in 20 to 30% of users.
So it's not stopping the egg.
Not always. The efficacy relies on purely local actions in the genital tract. Firstly, it ensures that the cervical mucus is thick and hostile to sperm penetration. And secondly, it interferes with the timing and receptivity of the endometrium, making it out of phase with fertilization.
So it interferes with implantation.
Exactly. It creates obstacles rather than stopping the egg production entirely.
We hear about different formulations, like monophasic and triphasic pills. What's the goal of varying the dose?
The primary goal, especially with triphasic pills, is to reduce the total annual steroid dose received by the patient. Triphasic pills attempt to mimic the natural fluctuations of the menstrual cycle,
How so?
starting low and increasing the dose of either or both hormones mid-cycle. While this reduces the overall drug load, it doesn't significantly change the efficacy or the general risk profile compared to a fixed-dose monophasic pill.
Moving beyond oral tablets, let's look at injectables like Depo-Provera. They're highly effective, but they come with some significant drawbacks that can impact quality of life for months or even years.
Injectables are highly reliable because, adherence isn't an issue. But the trade-offs are significant. The continuous high-level suppression of gonadotropins often leads to complete menstrual disruption, and Maria cessation of periods is very common.
And the return of fertility can be a problem.
That's the major clinical limitation. The unpredictable return of fertility, which can take anywhere from 6 months to 2 or even 2.5 years after the last injection.
And that prolonged hormonal suppression has a direct impact on bone health, similar to what we see post-menopause.
Precisely. Because the injectables suppress estrogen levels so effectively for a prolonged period, they can lead to a measurable decrease in bone mineral density after a few years of use. This is why long-term use requires careful consideration.
And they can have other side effects.
Yes, women may experience temporary low estrogen symptoms like hot flashes and vaginal dryness, even though they are contracepting.
Let's turn to emergency contraception, which has also evolved recently.
The standard is levonorgestrel, taken as a high single dose, ideally within 72 hours. It works primarily by delaying or inhibiting ovulation if it hasn't happened yet.
And ulipristal extended that window.
As we mentioned, ulipristal has extended that window to 120 hours, offering a much longer safety net. It is crucial, however, to stress that these are for accidental exposure only. Their failure rates are significantly higher than regular, scheduled hormonal contraception.
Let's do a final risk-benefit analysis for regular combined pills. What are the serious risks, especially for low-dose formulations?
The most serious risk remains venous thromboembolism and pulmonary embolism, and that's attributed directly to the estrogen component's effect on the liver's clotting factor synthesis.
But the risk is low, right?
The risk is low, perhaps 2 to 4 times higher than a non-user, but it is significant for specific populations. Women over 35 who smoke, those with moderate to severe hypertension, or diabetics.
And what happens once a woman stops taking the pill? Does that risk linger?
No, thankfully. The risk normalizes very quickly, usually within weeks to a few months after discontinuation. The effect is entirely reversible.
The absolute contraindications, then, are directly linked to these vascular and hepatic risks.
Absolutely. If a woman has a history of thromboembolic disease, active or severe liver disease, or an estrogen-sensitive malignancy like some breast cancers, combined hormonal contraceptives are contraindicated.
And surgery is a concern.
Yes. Furthermore, if a woman is scheduled for major surgery, the estrogen component must be stopped 4 weeks prior to minimize the risk of developing a postoperative blood clot.
Now, let's end this section on a positive note. The health benefits, the non-contraceptive advantages, are significant and often overlooked.
They are powerful and they deserve recognition. Using oral contraceptives actually provides a significant reduced risk of developing 2 major female cancers, endometrial carcinoma and ovarian carcinoma.
And they help with periods themselves.
Yes, they also lead to reduced menstrual blood loss, which combats associated anemia, and they are excellent at alleviating dysmenorrhea, painful periods, and premenstrual tension. For many women, these benefits significantly outweigh the small risks.
Finally, before we look to the future, let's mention that unique Indian SERM contraceptive, or meloxifene.
Meloxifene, or sencromin, is a fascinating alternative because it uses a highly tissue-selective approach for contraception. It's a non-steroidal SERM, that exerts its primary estrogen antagonistic action specifically in the uterus.
What does it do there?
It suppresses endometrial proliferation.
So it doesn't stop ovulation. How does it prevent pregnancy?
It works by creating what's called uteroembryonic asynchrony. Essentially, it throws the timing off. The uterus is not ready to receive the embryo, which leads to a failure of implantation.
And the rest of the body's hormones.
The remarkable trait is that pituitary, ovarian, and other systemic endocrine functions remain virtually unaffected. The menstrual cycle itself is generally not disrupted, although it may become somewhat longer or irregular. It provides contraception without that full systemic hormonal suppression of the combined pill.
We've established just how many complex, targeted, and effective options exist for female hormonal control. Yet finding an equally effective and reversible male hormonal contraceptive has remained one of pharmaceutical science's most difficult holy grails.
It really has.
Why is this challenge so monumental?
It comes down to a matter of scale and biology. In female contraception, you need to suppress the release of a single ovum once a month. For male contraception, you must achieve complete or near-complete suppression of sperm production.
Because there are millions of sperm.
Millions of spermatozoa are released in a single ejaculation. Any method that doesn't reduce the sperm count to virtually zero is likely to fail.
And the physiological timeline is working against scientists.
Absolutely. Spermatogenesis, the process of sperm creation, takes approximately 64 days. This creates a long latency period. If you start a drug today, it takes over 2 months before infertility is achieved, as the existing sperm in the system clear out.
And the return of fertility is also slow.
Slow and often unpredictable once the drug is stopped.
Beyond efficacy and timing, the major hurdle seems to be the quality of life issue tied to testosterone.
This is the primary reason hormonal methods fail commercially. To suppress spermatogenesis, you have to suppress the gonadotropins, which naturally drive testosterone production in the testes.
So if you shut down sperm,
If you successfully suppress sperm production, you simultaneously inhibit testosterone secretion, and the result is unacceptable side effects: loss of libido, erectile dysfunction, muscle mass loss, and potential mood changes.
so if you give a male estrogen or progestin to suppress sperm, you risk feminization or severe testosterone deficiency. If you give testosterone alone, it can suppress sperm, but usually not completely enough. It's a circular problem.
It is. Most hormonal methods require adding back large amounts of exogenous testosterone just to maintain libido and secondary male characteristics, which creates a really complex regimen. And even then, achieving the necessary level of suppression is difficult without extreme doses.
Let's focus on the most intriguing failure, the Gossipol anecdote. This was a non-steroidal drug that showed immense promise.
Gossipol, derived from cottonseed, was a huge, exciting discovery back in the 70s and 80s. It was non-steroidal, meaning it didn't interfere with the hormonal feedback loop.
How did it work?
It worked by direct toxicity to the cells in the seminiferous tubules. And crucially, it suppressed spermatogenesis effectively, without affecting libido or potency, because it didn't suppress the production of testosterone.
If it achieved the goal suppression without impacting libido, why was its use dropped entirely?
The serious critical side effect proved too dangerous. Gossipol caused hypokalemia, which is a severe drop in blood potassium levels due to excessive renal loss of potassium.
And that led to?
It led to attendant muscular weakness and, in severe cases, even paralysis. Given the potentially permanent and life-threatening safety risk, its use had to be abandoned globally.
So it underscores the challenge.
It really does. It underscores that for male contraception, the bar for safety and lack of systemic side effects has to be incredibly high.
This entire deep dive has been a lesson in chemical complexity and unforeseen consequences. We started by understanding that a single modification to natural estradiol gave us the orally active pill, and we ended by recognizing that small chemical differences are the difference between a life-saving breast cancer drug and an agent that causes fatal blood clots.
We've really established that hormonal control is always a calculated trade-off. We saw the profound metabolic difference between oral and transdermal estrogens, where the former maximizes clot risk due to those first-pass liver effects.
While the latter minimizes it.
Exactly. And we also clarified the complex risk balance in cancer treatment, where you exchange the risk of VTE and uterine cancer with tamoxifen for the accelerated bone loss associated with aromatase inhibitors.
The history of attempts, especially in male contraception, truly illustrates how hard it is to achieve biological perfection without compromising quality of life. The systems are so interconnected that suppressing one function inevitably impacts another, often with severe side effects.
Indeed. We've seen that the simple goals of maintaining bone density, or preventing conception, or treating cancer require an incredibly sophisticated chemical strategy. It really makes you think about the future of targeted medicine.
And that leads to a final thought for you to explore. We've seen the success of SERMs in tissue selectivity, but we know the receptors themselves are complex. We have two distinct estrogen receptors, ER-alpha and ER-beta, and two progesterone receptor isoforms, PRA and PRB. So considering the precise selectivity we already have, what emerging pharmaceutical frontier, perhaps one focused on targeting specific receptor isoforms rather than the entire class, might finally solve the complex dilemmas inherent in hormonal medicine, allowing us to deliver the full benefits without the systemic side effects?
That is the next chapter researchers are scrambling to write.